Welcome to today's virtual panel discussion. I am Ricardo Rivera, your host from the American College of Healthcare Executives National Office. Before we get started, I'd like to go over a few items. For the purposes of noise control, your lines will be muted for the duration of the session unless there is an active discussion, at which point you may unmute yourself to talk. You will also have the opportunity to submit questions throughout the discussion through the chat panel, so please feel free to submit your questions as needed during the discussion. Today's session is worth 1.5 hours of face-to-face education credit. Credit will be applied to your ACHE account in approximately 2 weeks following the end of the session based on your attendance and completion of the evaluation. To ensure your credit is applied, please be sure you are using the Zoom platform on a computer or the Zoom app on your smartphone. Also, be sure the name you use for the Zoom session matches the name of your registration. This session is being recorded and will be available within 48 hours by navigating to your My ACHE account and selecting My Online Learning from the Helpful Links section on the right side of the screen. Now it's my pleasure to introduce GAHE's President, Trent Lin, Chief Executive Officer of Eastside Medical Center. Trent, I'll turn it over to you.
Hey, thank you, Ricardo, and thank you to everybody on the line today and with us on Zoom. Certainly a great opportunity for us to gather again over our virtual lunch and really share a timely and important topic within our country and across the world right now. Obviously, you're going to hear from experts in the field that are local here to the greater Atlanta area as well as Georgia. Which is a real privilege. When you think about equity of care and the Institute of Medicine's definition, it's care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And as our panel spoke with me before this session today, certainly COVID has shed light on the opportunities and challenges, and certainly the vaccine that we're rolling out now is even in a greater way shed light on the fact that we still have tremendous opportunities across our country in regards to equity of care. So looking forward to this panel discussion. Again, we have experts with us today that are going to really help us to delve into this topic in a deeper way. Want to start off with really recognizing our sponsors. We can't put on events like this without amazing sponsors. And our platinum sponsor, Wellstar, thank you very much for your commitment to GAHE and our mission. You can see here our gold level sponsors: Cancer Treatment Centers of America, Sound Physicians, Metro Atlanta Ambulance Services, Beck, Protivity, Phillips, and HCA TriStar Division. And then our silver sponsors: DT Spade, KCA Firm, SSR, and Nagel & Associates. Again, thank you so much for all you do to help us, again, continue our mission. Just a quick slide on our upcoming events. You can see here, again, a host of timely and on-point topics that we have a chance to go over the next couple of months. We encourage you to continue to make sure that you're hitting up all of our social media outlets and our website to make sure you're staying abreast of future events. One big event that's coming up that's new to GAHE, but something that's spawned from some of our tremendous volunteers, our GAHE week. This will be the week of March 8th through 11th. You can see the breakdown of daily events that will be scheduled, and really just an opportunity to learn more about what we do as an organization, learn more about our committee structure, and learn more about how you can get involved. Again, this is a fully volunteer led organization, and so to have your interest and influence and certainly hands-on efforts would be a tremendous honor for us, and certainly an assistance for us to continue all the great work that's going on with GAHE. And stay connected, as I mentioned. Here's some of the outlets. www.gahe.org is our main website. Also, we have a Facebook account, so make sure you go on and like us on Facebook. Stay connected to us via LinkedIn and GAHE and on Twitter at GAHE Connect. Getting involved is an easy thing to do. And again, using GAHE Week as an opportunity for you to learn more about what we're doing as an organization and what our committee structure looks like. You can see here, communications, career development, fellowship advancement, membership growth and satisfaction, our physician executive group, programs, sponsors, and then really proud of our newest committee, diversity and inclusion. That committee just formed in partnership between GAHE and NACI, and really proud of the work that will take place with that committee. So a lot of ways to get involved, and we please ask you to reach out to our administrator, Bruce Lloyd. You can reach him at admin@gahe.org. All right, now on to today's program. Again, equity of care couldn't be a more timely and important topic in our healthcare field today. Really proud of our group of panelists who will be moderated by a national leader with Sound Physician. And I have the privilege and honor of introducing Dr. Gregory Johnson. You can see here the Chief Medical Officer with Sound Physicians. And one quick clarification on the bio for Dr. Johnson. He actually has recently taken on an even broader role in not just regional clinical operations, but as Chief Medical Officer for Sound Physicians, he actually has the national responsibility for the organization. And you can kind of see the breakdown of his responsibilities, but I do want to share a little bit about his background. Dr. Johnson's a graduate at McGovern School of Medicine, the University of Texas Health Science Center at Houston, and completed his residency training in both internal medicine and family practice medicine at Ochsner Clinic in New Orleans. He's a fellow in the American Academy of Family Physicians, the American College of Physicians, and a senior fellow with the Society of Hospital Medicine. So we are certainly privileged and honored to have a great mind in the field, Dr. Johnson. And from this point on, I'll let you take it over.
Thank you so much, Trent. It's a real privilege to be here, and really eager to hear the discussion from our panelists. Next up, we have Ms. Joanne Sims-Hill joining us from Piedmont. Joanne, if you would like to make a few comments about yourself to the group.
Thank you so much, Dr. Johnson. I am honored to be on this esteemed panel. I just realized I said everyone is clinical but me. That in itself is diversity and inclusion. I'm loving that already, Trent. But I am the Executive Director of Diversity and Inclusion at Piedmont Healthcare. I'm still relatively new to the organization, having joined Piedmont 19 months ago, the first person ever hired in this role. I'm thrilled to be here to lead the effort to make sure that we have an environment and a culture where there is diversity, when there is inclusion as well. I spent almost 30 years at AFLAC as their Director of Diversity and Inclusion and Employee Engagement. So I'm looking forward to the conversation. Thank you for having me today.
Thank you, Joanne. Next, we'll have Dr. Jyoti Sharma. Dr. Sharma.
Thank you so much. Thank you, Dr. Johnson, and thanks to everyone for having me here, and many thanks to Trent and Amanda Mewborn for including me in today's discussion. I am a native Atlantan, which I understand is hard to find these days, but I grew up in Tucker, Georgia, and I went to Emory for medical school, and after that I did my internal medicine residency at Beth Israel Hospital in New York. And then I actually followed Dr. Johnson to University of Texas. I was in Houston doing my cardiology training there. And I can say that I'm so glad I'm not in Houston right now. So I'm sorry that all those folks are going through that there. But after I finished my training, I joined Piedmont Heart here in Atlanta, and I have been here since 2013. You know, my clinical area of focus, I have a love of echocardiography, and I did extra training in that. But really where I focus my clinical care is women with cardiovascular disease. And so that's where I really spend the majority of my time when it comes to seeing patients. And most recently, I've taken over in a new role as the medical director of Atlanta, but I also have responsibilities as the Women's Heart Program director for all of Piedmont Healthcare. So thank you again for having me here today.
Thank you, Dr. Sharma. Next, we have Dr. Patrice Walker. Dr. Walker.
Good afternoon. I'm Patrice Walker. I'm a native of Central Georgia. I attended Georgia Tech and then Mercer for medical school and did my residency in OBGYN here. And prior to transitioning into hospital administration as the chief medical officer at Atrium Health Navicent, my background was in medical education. So I taught in the OBGYN residency program, as well as held a position with Mercer University School of Medicine as their Dean of Diversity, Equity, and Inclusion. And after which I transitioned over into hospital administration, where I've been in the role of chief medical officer since 2019. Prior to that, I was deputy chief medical officer for a year and have just been enjoying the ride. And I too am glad to be a part of this panel and really excited about the conversation we're about to have.
Thank you all for your introductions and providing a little bit of background. For all of the participants, we're going to first go through a few questions that we wanted to put to the panelists just to prompt discussion. For those of you who have additional questions, I encourage you both now and at the end of the session, please put them in chat. We will look for those questions and after we get to the end of the formal questions that we have, we'll move into the chat questions as they come through. So please don't wait until the end. We'll be able to look through those and make sure that your questions are being answered as we progress through this panel. So I want to jump straight into it. And I think Trent was fantastic in leading off in saying, hey, we need to think about the fact that we're still in the times of COVID and still dealing with the current pandemic. And want to start with this question to our panelists, and first with Dr. Walker. What has changed or been identified as a need to change within your organization with respect to access to care, particularly with respect to the pandemic?
That's such a great question. And I think the biggest thing that we've identified that probably, everyone on the call has identified in a similar fashion is just the sort of underlying distrust in medicine that's still out there. And I'm saying this in terms of course, vaccine uptake. We have this pandemic and initially there was really no treatment. There is no treatment still. It's supportive treatment. And so the development of the vaccine was so important. And we have that now. We're all very excited about it. And yet we are sort of struggling to get uptake with the vaccine. And the reasons are multifactorial, but one of the biggest ones that we hear is sort of an underlying distrust of the development process. And it's mainly from our minority, community and minority employees. And so this isn't new. It didn't just happen, because all of a sudden we're in a pandemic. It's something that's been around, and yet we really haven't focused on that when it comes to care delivery. It's all about, access to care and social determinants of health, and yet there's this underlying need to understand that there are additional factors that go into how people access care. And I think that's something that a lot of us are realizing. We've got to incorporate that into our plans moving forward.
Thank you. I don't know if Dr. Sharma or Ms. Hill wanted to augment some of those comments.
Hey, yes, I can just kind of share. I was chatting with the group before this conference even began. So, I see clinic patients, or I'm in the hospital rounding a lot. And as I am chatting with my patients, there's a lot of questions. I'm a cardiologist. I don't claim to be a world expert in COVID vaccines, but, anyone that gets an opportunity is really asking, just kind of like what Dr. Walker mentioned, how come the vaccine is so fast? How can you even know if this is going to work or if there's going to be any long-term side effects? And It's funny, I had a conversation with Dr. Hill maybe just a couple of weeks ago, and something she said really stuck in my mind, and that's this idea of meeting patients where they're at, really understanding their specific concerns about their vaccine. So when I was rounding in the hospital, I was chatting with some younger nurses, and their concern was, well, if I take this vaccine, am I going to be able to have a baby in 5 years or 7 years? I got to be honest, I'm done having my babies. Like, that thought had never crossed my mind. And to hear these young women saying that, and to be able to kind of take that time, even as I'm rounding on the floor, and say, you know what, let's back up and let's really talk about that. I think Piedmont did a great job really kind of answering some basic questions for patients. We put together this video that included one of our physicians, Dr. Jane Morgan, and something that she said really stuck out to me, and that's that, you know, we've had viruses that are similar to COVID, and those have been around for a long time, since the early 2000s. And since that time, we've had, you know, nearly 20 years to map out the genome and figure out what these viruses look like. So though it may appear that we have worked rather quickly to figure out this vaccine, we've had nearly 20 years of a head start. And actually sitting down and explaining that to patients and using words like, we're using the spike protein on the outside of the COVID virus, and that's what we're using to, you know, mimic that and actually inject in you. I think patients get it. I think you can have those type of conversations, but I think it is really trying to spend this time and really figure out where all their individual concerns are. And I'm very fortunate, right, that I'm able to do that in these one-on-one interactions with me as physician to patient. But I think, you know, people like Dr. Walker, you know, and Joanne have a much, you know, bigger task, because they have to do that on a 1,000-person level for hospitals and large healthcare systems. And I think that's really where the challenge is meeting that such a large population of patients.
And Dr. Johnson, if I could just add something, first of all, I want everyone on the call to know that Dr. Sharma is one of our superstar physicians at Piedmont Heart, Piedmont Healthcare, and I'm honored to be on here with her. But I think one thing that you said and that Dr. Walker said, when we talk about equity of care and what's going on right now, a lot of people talk about COVID and, you know, 2020 being such a horrible year. And I see that, but I also see this as an opportunity to have courageous conversations that we should have been having all along. And so I was never one to want to quickly run into 2021 and say it's a new year, because we can keep having the same thing. There are reasons why there are inequities in healthcare. COVID just brought up something, as you said, Dr. Walker, that we've already always seen. But the question, hopefully for all of us, is, what are we going to do to move the conversation forward? It's COVID today. It's been hypertension in underrepresented communities and Black communities for years. It's heart disease. It's so many things, but we have to be able to fuel people's fears with facts. If I don't want to take the vaccine because I think I may get sterile, we have to give them that information. If I'm afraid to see a physician who doesn't look like me because I distrust them because of Tuskegee or something. And so I think that is a conversation that we all have an opportunity to participate in. So I consider this to be an exciting time to move the needle forward.
Thank you, Joanne. I'm actually going to stick with you for our next question and then move forward, which is, what methods are your organization using to strengthen care delivery to vulnerable populations?
Well, I think the first thing that we're doing is we acknowledge that there is a disparity. So you can only move that which you understand is an issue. And I think we've always been focused with that with Piedmont Healthcare. I think my role of diversity and equity inclusion just helps to bring the conversation forward that we are a huge healthcare organization centered right here in the state of Georgia, but yet there are differences between Piedmont, Atlanta, between Columbus, between Mountainside, all of our 11 hospitals. People, I've always stated that a company cannot be separate from the communities of which you serve. And so in order for us to move the needle, as Dr. Sharma says, we have to have conversations. What are your fears? What are your concerns? What have you seen? I may need a different doctor. And so I think we are empowering our great medical directors like Dr. Sharma all throughout our organization of understanding what is it that is keeping people from going to the doctor, preventing people from making a decision, because at the end of the day, the promise of Piedmont is to make a positive difference in every life we touch. You know, our doctors are there to heal, but we also want people to take ownership of their medical decisions. And so we're doing that through our different committees, by understanding the communities that we serve and talking to our patients and taking that feedback and bringing that into our organization. I'm excited to be a part of Piedmont during this time.
Dr. Walker, anything that you want to add from the Atrium Navicent perspective?
Sure. I think one of the biggest things that we are starting to do is focus on what we're really good at. And I say that to mean, you know, in the past, we sort of will identify a gap or a need and then say, well, let's build a program around this. Let's do an intervention. And that's fine, but we become very stretched thin, and it's the new shiny program for a while, and then, oh, well, the funding's a little, you know, shaky, or who's running the program? This person left and it was their baby. And so we're starting to move away from that and really focusing on community partnerships. You know, if there's an organization out there that's already doing it, then let's partner with them. We don't have to reinvent the wheel. We've just got to be able to communicate with them and identify a patient or a community that has a need, know who it is that's already meeting that need, and can we help them? Can we help them scale? Can we help them scope? Can we do referrals or what have you? So we're really trying to focus on let everybody do what they do best, and let's all work together so that we benefit from the collective resources that we already have in the community. When we do our sort of community resource assessment, we actually found out that we have a ton of resources. A lot of them are duplicative. A lot of them are, well, this is what we primarily do, but we also do A, B, and C. And so we decided, wow, we don't need new resources. We need to optimize how we're using the resources that we already have. So moving forward, and especially now that Navicent is part of the Atrium Health enterprise, we're really going to focus on optimizing those relationships that we have with external, you know, organizations and leveraging that so that we close those care gaps.
Thank you for that. Dr. Sharma, turning back to you, the question is, what educational offerings has your organization provided to you and your staff to develop skills and cultural competency to provide quality care to patients of diverse backgrounds?
Yeah, that's a great question. And actually, Joanne may be able to kind of help answer that, I think, on sort of a Piedmont Healthcare larger level. If you don't mind, I do want to circle back to something that Dr. Walker and Joanne were talking about, and that's this idea of kind of partnering with other with organizations that are already out there in the community. And I think that's really important, right? Because when we come in as some outside group, or I'm supposed to be some expert cardiologist, these women in particular that I'm looking after don't know me from another person on the street, but they may already have a relationship with this group, with this faith-based organization, with this business, with this person that they already know. And that is really important, I think, to kind of build on top of that. I'll tell you as an example, for our Women's Heart Program, just on Monday, we were down in Fayette and Coweta counties doing heart screenings for those women there. They tend to be primarily African-American women. These are women that are either underinsured or not insured. And we know that cardiovascular disease is the #1 killer of women and disproportionately affects these women. So again, we did not have to, as Dr. Walker was saying, reinvent the wheel here, but we created this relationship and we're able to go down with our expertise and our, and all the other services and things that we are able to provide and say, look, here's the way that we are going to start partnering, building rapport with these patients and actually getting them the care that they need. And I think that's really, really important. The other thing that I wanted to say that sometimes I really did not think about until I became a medical director, and someone told me that I got to be in charge of the doctors that I wanted to hire. And I thought, wow, terrific, I get to decide that. And, when and Joanne also mentioned, this also when it comes to talking about equity of care. And I think the diversification of the workforce becomes incredibly important. You know, the Sullivan report that I think was initially published, I think it must have been in 2016, said that the lack of diversity amongst healthcare professionals may actually be even more responsible for healthcare disparities than health access and outcomes, right? Even more so than health insurance. So I think, and there's so much data that's actually quite robust that shows that when a patient has a physician or a healthcare provider, whether that be an APP, right, or a physician, that's someone that they feel that they can connect with. And a lot of that data was based on ethnicity and gender, that those patients tend to trust that care provider. So when I tell you it's a good idea to get the vaccine, it's a good idea to get your heart screened, that they're more willing to buy into that. And so I think that's also actually a really important part of this discussion, is making sure that we have the right people in place to deliver the message. And I think that's just a really foundational aspect. And sometimes I think we're so caught up in the, oh, we got to have telemedicine. Don't forget, we got to get, you know, again, access to care, which is important, but you can't put the roof on the house until you have the foundation there.
No, that's fantastic. And I would want to actually pivot to the point of expanding leadership opportunities for ethnic minorities in healthcare and health service management. So Dr. Walker and Ms. Hill, would you guys please expand upon that aspect? Because I do think it's a critical area that we want to underscore in addressing health disparities.
Certainly. So one of the things that that Joanne said initially was a big factor for us in terms of identifying, you know, who we currently had in leadership, what our current leadership, you know, looked like, and we realized it was very not diverse. You know, so first of all, it was knowing what we had, and then determining, okay, what do we want? What do we want to increase? And then how are we going to do that? And we actually, we looked at it all the way from the level of the board of the hospital, all the way down to our frontline people, and realized that at every level we had work to do. And so going back to what Dr. Sharma said, you know, the board, having the right people in the right places, because the board helps set the direction, the priority for the organization. So if you have a diverse board, then a lot of those decisions that flow down are going to have a diverse, you know, scope and basis. So we really focused on increasing the diversity of our board. We just hired our first Black CEO that Navicent has ever had. And you know, having an increased number of minorities in our executive suite and downward, you know, I think that that's going to go a long way towards making sure that the decisions that are made are diverse and inclusive decisions. Not that they haven't been historically. However, you know, just call a spade a spade. We have work to do, and so I'm really excited about the direction that the organization is going, and putting our money where our mouth is, and not just saying that we want to see changes, but you know, walking that walk.
Wow, I'm trying to be on my best behavior because I'm so passionate about this topic. I mean, I'm at a place in my life where my purpose and my passion and my paycheck have all aligned. And so to everyone on this call, I see some pictures, so I know what some of you look like, don't know what everyone looks like. But I think we should level set diversity, inclusion, and equity. You know, when I started at Piedmont, I used to say every time I would speak, if you stop at what you see, you're going to miss out on the best part of me. Don't stop here at what you see. To your point, Dr. Walker, we all should make a conscious effort to look at our organizations, because diversity starts at the top level of your organization if you want it to be effective. I read somewhere they said, well, diversity is a fact, but inclusion is an act. From my perspective, and I brought this into Piedmont, when I look at diversity and inclusion, it's really about improving performance. Some of you say, well, why do you say that? Because when everyone believes that they have a seat at the table and their voice can be heard, morale goes up. engagement goes up. You don't have to ask doctors to take care with their patients. You don't have to ask nurses to work overtime. You don't have to ask the person in EVS to make sure that COVID room is clean, because they feel that they are a part of it. That's why it's so critical. But I also say to Piedmont, everyone must have a seat at the table. That means each and every one of us. And it is not an attempt for this reverse discrimination or affirmative action to say that our brothers who are Caucasian males, you're not important. You are critical. You are critical. I don't want to take your seat. I just want to sit next to you so I can understand what it took for you to get there, so that 20 years from now, my children and my grandchildren are not having the same conversation. That's the work that we want to do. And we all have to start and be open to say, I'm going to start at my board. I'm going to see what it looks like. And in the staff that you're a part of, when you go into these meetings, whether it's virtual or in person, if everyone looks like you, I challenge you to think about the fact that there's innovation that you're missing. There is creativity and experience that is not at the table if we all look the same. The United States is a melting pot of diversity. Even our organizations, as you said, most of our organizations are diverse because particularly here in the state of Georgia, the state is changing. The key is inclusion, equity, and finally, belonging. And we can get there, but we got to do it together with every single person on this call and the organizations that you represent.
We can absolutely feel your passion, Joanne, when you're getting into this, and you are absolutely on your best behavior in terms of making sure to communicate that. So you're in a good place.
Matt Enright?
I do want to return to the prior question about educational offerings, specifically to ensure developing the skills and cultural competency to provide quality of care to patients of diverse backgrounds. Again, I'll start with you, Dr. Sharma. I know that you wanted to share with Ms. Hill in terms of that, but we want to make sure that we hear from all three of you in terms of any specific and concrete activities that you are developing within your institutions.
Yeah, I mean, I can again share from my perspective of what we're doing with the Women's Heart Program. And that is, again, that we have decided that we know that there are, within all the hospitals, that our hospital system, there are certain communities around some of those places that that really need our help. Although women with cardiovascular disease, I would say that is the need, is every woman, because most of us do have risk factors for heart disease. But there are some communities even within women that need sort of that more help. And so what we have really done is, again, said, look, who are those partners in the community that can help us? And that we have really tried to use those other groups, again, whether they're faith-based groups or other kind of, community-based organizations of where we're trying to go, and sit down with them and say, you help us understand kind of what is the best way to communicate with, with the patients and the folks that are in this community. And I just am not sure that we were always doing that before, is doing this outreach to other people and saying, I don't pretend to know best, please help me understand. So that is one thing that certainly we've done, as I said, a very conscious effort. But Joanne may be able to speak sort of more from a top level about what Piedmont Healthcare in particular has done.
Absolutely. And a couple of months ago, I received additional responsibility for our learning functions as well. They've now moved under to my organization. And so we are in the midst, as we speak, of preparing a cultural sensitivity course that we're going to roll out within the organization. When I arrived at Piedmont, I saw that we did have some training, but that it really had not evolved into the clear conversations that we need to have in today's society. We need to talk about systemic racism. Those are not bad words. We have to talk about it so we can do something about it. So we're working on some modules. I have been asked from the nurses accreditation program to the APP program, to also look at diversity and inclusion in all of our offerings and training. And to add that, we're also working on unconscious bias training and how we can roll that out on the physician side and within our organizations. In order to move those things, we have to have clear conversation. And the last thing that we're doing with our EPIC system, there was a module that we had not turned on within Piedmont, which speaks to the SGN, the sex, gender, and name, so that we can call people what they want to be called. We have transgender LGBTQ people coming into all of our organizations. If we want them to come to us, if we want to be their healthcare provider, we have to ask them, how do you want me to address you? What are the sensitive things that we need to know about you? And so those are some of the things that that we're working on that will be rolling out within the next 60 to 90 days. I'm really excited about that.
Thank you. Dr. Walker, anything from the Navicent and Navicent Atrium?
Yes, so we have a couple of things. The main thing is our health equity champions. So back in 2017, 2018, we developed the health equity champions program. And we wanted every unit, every department to identify at least one person initially that would be a health equity champion. And this person would receive special training, special education, and after which they would go back to their unit, back to their department, and be sort of the resource, local resource, local advocate, as well as a conduit of information from, administration and otherwise outside of their department to help bring that into their department. So they received in-person training, which is now transitioned to virtual. Even pre-COVID, we realized that we couldn't do everything in person, so we had a virtual component to that. And that training included implicit bias training, health literacy training and communication, as well as some of our internal numbers that we had not really historically been transparent about. What was the makeup of our employees? What was the makeup of our again, board and executive team, and how were we working to, make it more diverse? And we got such good feedback from the health equity champions. They got our certificate, they got a pin, we made them feel special, and they went back to their unit and said, hey, look, I got some things to share with you all. And the feedback that we got was so good, especially about the implicit bias training, that we added that to our annual training that all employees have to do every year. That includes the, compliance training and things that are not, so exciting. And we put it as part of that Care Learning, our digital application, so that every year, everyone has to review that training. So you don't just get it one time, you get it over and over and over again, because we all know that you don't just wake up one day and all of a sudden you think differently and you do differently. It's really something you have to work at, and it has to be ongoing. So that's the biggest program that we have. And even though we started with having, one person from the unit and department, now we've sort of opened it up to say if other people, there are 3 or 4 people from the same department that want it, we want everybody to have the training. So we haven't done it recently. We got to get it back going, but for a while there, we were having really regular cohorts of people go through it, and it was across the system too. So at all of our facilities, not just our main facility, we had those individuals. So we're really proud of that program.
Fantastic.
And Dr. Johnson, I'll just say one thing. What's been so interesting to me is, again, I spend the vast majority of my time taking care of my patients and working with my colleagues, right? I am a clinician. And when we sit down and I talk to my partners and say, hey, look, here's something that's really important, is that we need to work on, diversification of our workforce, or we need to be cognizant about some implicit bias that we may have when we're taking care of patients, right? That's just, what was so interesting to me is, I was kind of a little bit nervous to have that conversation with my partners. And as soon as the words were out of my mouth, everyone was looking around the room going, oh yeah, no, you're right. Absolutely. How do we do that? What should we do? And I think sometimes it's just putting it out there. I have found, and again, this is a pretty micro level I'm talking about, but even having these kind of open conversations with colleagues, I have just been so pleased to see that people are willing to talk about it, and people are willing to say, yeah, let's move forward in a new way. I agree. It's something that maybe we don't think about or talk about enough. And I guess that's just been a really nice experience to have that. So even though we are doing all these, I mean, I think this is terrific what Dr. Walker was talking about, having this kind of like go-to person in each section. That's a wonderful idea. And I think it's kind of the same thing, going back to your little microcosm and having that conversation that's really going to kind of bring this to the forefront. And that has also been our experience here, that's actually been a really good way to do this.
I think it's a fantastic approach, because you are demystifying and de-escalating what I think a lot of people think are uncomfortable conversations, and realizing, no, we can have these. We can make sure that we are providing, we're acknowledging and then providing general awareness, and saying, this is a safe space and a safe discussion, and you know me and trust me, the same conversations you've been having with your patients, Dr. Sharma, in order to provide the ability to, again, build from that. So even if we can't necessarily start at the board level, we know that we can create the environment where those discussions can be had. I do want to return to one last question, or at least one of our formal questions before I get into the chat questions. And again, go to you, Dr. Walker. You had mentioned before about, hey, identifying sort of gaps within your existing structure and then working to build on those. Can you reference any particular policies or any just sort of specific areas that you and your colleagues in your organization identified in that process, and sort of what came from it in terms of addressing gaps in care?
Yeah, as far as policies go, I think that we still have a lot of work to do in that realm, because we tend to have projects, and those projects get focused for a short amount of time, and then they sort of fizzle away. And so we need to transition from projects to policies, so it doesn't matter who the person is, or it doesn't matter who the owner is, or that it's just part of our workflow. And one way that we're exploring, our Atrium Health Enterprise level, they have an application that's sort of lives within their EMR, that allows them to do a social needs assessment on every patient that comes in the door. So at the same time that the nurse is inputting their home medications and all of the normal things, she's also asking about, do you have transportation? Are you food insecure? There's a whole, checklist. And those things actually go into the medical record and are a part of, the care that patient gets from the time that they're in the hospital and all the way to the discharge planning, so that we've already identified when the patient came in that they had food insecurity, and they're diabetic. We've changed their insulin regimen. How are we going to help them identify somewhere where they can go, that they can have food that they can afford, that's going to help them, maintain these changes that we've made? So we are really learning from our enterprise teammates how we can begin to incorporate that, so that it's part of our workflow, part of our policy, that it's not just a project somebody's working on. I would say that that's a major thing that we're going to be working towards in the future.
Joanne, anything that you would like to add from the Piedmont perspective on policies to address gaps in care?
Well, I love something that that you said, Dr. Walker, moving from projects to policies, right? Because a project, just by definition, means it's a set start and a set finish. And the care of people, it can't be set. I mean, we want it to be lifelong. And we also, as you said, we want our people to come to us, not when they're, stage 4 prostate cancer, when we could have addressed that a lot longer because of the trust. And so we have something very similar. I call it the holistic approach to a person, not just the medical need that they have today, but like you said, the transportation to get here. How am I going to get home? The food the environment. I am such a, I could go do a whole panel about being such a foodie on healthcare. And as I got older, when I realized how the foods that I were eating, how it's impacting my body, it could make you healthy or not healthy. I'm big on yoga and water, it's a whole different subject. But I think we're doing something similar. And that's why I say that our organizations, our companies cannot be separate from the community. The work that Dr. Sharma said in going to Fayetteville Hospital and understanding that women need that. And so we're continuing to do that, but to also do our surveys to ask patients, what do you need? I mean, I think that is one of the smallest things I think we overlook in life in general. If you really want to know how I feel, why don't you ask me? Don't ask my brother, don't ask my mother, don't ask my doctor. Ask me what I need, and I can tell you. And then we build upon that. It bridges trust, opens communication. I mean, we're talking about from a patient-physician standpoint, but I'm saying even with our employees, ask them what they need. Ask the charge nurse what they need on the night shift. Don't ask the director who's there during the day. Go to the EVS and ask them what they need as they work with our patients. So I think these conversations, again, these courageous conversations that may be uncomfortable at times, but it will help us get the knowledge to make the changes that we need to make for everyone.
Fantastic. So that ends sort of our formal questions that we wanted sort of preset and initiate the discussion. I encourage, we have a handful of questions in the chat, but I encourage any of the participants, please submit any questions that you might want to have for the panelists. We do have two that are in here right now. I'll start with one of them, which is in terms of discussing diversity, inclusion, and belonging, do you include the culture of active and military, it says active and military veterans. I think it means active duty and I guess retired military veterans. So I'll put that to the group and you guys can answer individually.
Well, I can start. As part of our diversity and inclusion and equity initiatives, we definitely include the culture. I think here, as Dr. Walker said, I think that we have an opportunity to do more. One of the things that we're working on at Piedmont Healthcare is a true identification of who our veterans are, because I mean, that's not on our application. And so one of the things that we're trying to do is make some changes to capture that. Like we had today and we did a big thing to celebrate, but when we look into PeopleSoft, we see, oh, we have 3% veterans. They're higher than that, to make sure that people self-identify, and then to bring them into our councils that we have to better understand what is it, again, asking them, what do you need? When you transition from military life to working here, what are the things that are concerning to you? What are the things that are critical to you and that you have knowledge of for people who are retired? So it's taking it again and asking people what they need, because it's different. I am a military brat, I'll use that term. My father, retired military, Fort Benning. And so my perspective of having traveled is probably different from another person's perspective. But I tell you, the leadership qualities and things that we experience with people who've been in the military, it's something that we need to hear more and more about. So we're continuing to improve upon that in our efforts with our diversity councils at Piedmont Healthcare.
Here at Navicent, I will say that I don't believe that we have anything specific in terms of active or retired military veterans, and that's probably unfortunate. Of course, we have, Warner Robins Air Force Base that's very close. We also have a VA hospital in Dublin that's an HCA facility, but we have a lot of common patients. So that's something that we probably should focus on more than we do, just because of, we have those people in our community that are an important and large part of our community.
So we'll direct our next question to our two clinical folks on the call. And the background of the question is, in South Georgia, there are large populations of non-English speaking migrant workers that come into the state and work agribusiness. Do you have any specific suggestions on how to address their health needs and or chronic conditions?
Sure, I'd like to take that one. As part of our COVID efforts, we reached out to the Peach community. We have a critical access hospital in Peach County, and I say we reached out to them. They reached out to us actually and said, hey, we'd like to partner with you. What can we do to help? And so we had a really good relationship with them in terms of helping them prepare for the migrant workers. We helped them with screening, questions. We helped them with thermometers, and we also identified the best ways to communicate with the migrant workers through local radio stations, through local print media that was targeted to them. And we realized that, gosh, we really should have been doing this, the whole time. But again, this was one of the things that the pandemic really brought to the forefront, that we have a community here that has special needs. How are we going to help them navigate through this particular time? And so I think we can take what we learned specific to the pandemic and really moving forward, how can we continue to have conversations about other, healthcare needs that this population may have?
And, I would just add on to that. Again, as I'm having these conversations with my patients, but particularly those that may be immigrants or that are, maybe have a lower socioeconomic status, one thing I hear over and over again, it's really difficult to navigate these really complex healthcare systems. How do I figure out how I'm supposed to get a PCP or show up for this appointment, or maybe I don't understand this? And I think it just gets exacerbated. It's hard for anyone. My goodness, sometimes I feel like it's hard for me as a physician who's in healthcare, who's, going and getting healthcare from the place I actually work. And I find it difficult and kind of, it can be quite a task to navigate this. So I'll tell you one thing that we've done within the Women's Heart program is that we have these program coordinators whose part of their job for our female cardiovascular patients is to serve as navigators, and that they have that time, the space, the bandwidth. Heck, it is part of their job to help patients figure out where to go to get all the things that they need. And I feel very fortunate that we have those resources, but I think having those dedicated folks makes a big difference in actually, one, outcomes of our patients because they get the care that they need, but I think it also just really helps alleviate the stress that goes along with trying to figure out how to take care of you yourself or your family member. And we know that in particular, the vast majority of caretakers in the United States are women. That burden falls on our female patients. And so, when you're caring for children, you're also caring for elderly parents, and then may have some of these other barriers, whether it be language or transportation, whatever it may be. It really is helpful to have this other person that's there to guide you through the system.
Thank you. The next question: have you incorporated diversity, inclusion, and equity into your respective organizations' mission, values, and or standards of behavior? I'll pause there because there's a second portion to that question. So just do we feel that your respective organizations have incorporated diversity, inclusion, and equity into mission, values, and standards of behavior?
I can start with that, but I would like to alter that question and say we are in the process of incorporating it, because I think in my 19 months, to have set up the Office of Diversity and Inclusion, to have hired me into this role with a focus solely on that, it's an incorporation. We're on a journey at Piedmont. We're in year 2. It's a journey. It does not happen overnight. It's in our mission, it's in our promise and our values. We have a D&I statement, and we have strategic pillars that we are working towards in this fiscal year that are directed into that mission. when COVID hit, everything kind of halted in a lot of healthcare, and it did at Piedmont. And our CEO said, we're going to do three things. We're going to focus on quality, safety, and service. We're going to focus on our COVID financial recovery, and we're going to focus on diversity and inclusion. Those are the three things that we are committed to do. And then under DE&I, there are four things that we are focused on. And I'll just say very quickly, the first thing is increasing the number of ethnic minorities and women in leadership. That is something that was part of a narrative that we are here, but we are not in leadership positions, both on the physician side and on the non-physician side. We are also focused on giving education. Again, what is cultural sensitivity? What is unconscious bias? How do we talk to people who don't look like us? So we're working on training for everyone and giving them a plan of how do you move up in this organization. The third area was the activation of our diversity councils. I believe that the diversity council model is a more effective model for some organizations, as opposed to the ERGs, the Black Affinity Group or the Women's Group. And so we have everyone coming together. We have 14 councils, one at every hospital, and also in our system office and in our physicians enterprise, to address the needs of that particular entity, so that when it's Veterans Day, we all work on it. We're all working on Black History Month. We're all working on Women's History Month. Next month, we're going to actually feature Dr. Sharma. It's going to be one of the people we're going to feature at Piedmont Healthcare. And then the fourth area of our effort is looking at COVID and the effects on our community. How can we improve our presence in the community? So yes, it is changing, but we're not there yet because it is a journey.
And I would say for us, prior to joining Atrium Health, we already had a inclusive mission, and that continued once we combined with Atrium Health, and our vision statements or mission statements were very similar, and they were inclusive to the extent that they both spoke to the all, the everyone. So currently we are, our goal is to elevate health, hope, and healing for all. That for all is really the focus of everything that we do. And it's a simple 2 words, but it really embodies, what we mean when we say inclusivity is everyone. And we've been talking this whole time about meeting people where they are, and that's going to be different for different groups, and that's okay. We're going to have whatever resource or whatever their needs are, we meet them there. And so it really was a great alignment for us, for our organizations, when we came together and realized that we were already on the same page about that. I will say that we are excited because at the enterprise level, we have a much more well-developed Office of Diversity, Equity, and Inclusion than we had. And so we're very excited about being able to join in the efforts and not have to start from scratch, but be able to just say, oh, great, what are we doing? So that's been a huge benefit for us.
Mm-hmm.
I was pausing because it looked like some others had wanted to say something. So, all right. We do have another question. Can each of you speak to a unique, what you believe is a unique challenge about regarding diversity and inclusion for healthcare? And I'll give you guys a chance to think about that one. And then Dr. Sharma, I'm going to put you a bit on the spot in terms of being the first one to respond.
No, yeah. I like being on the spot. No worries. It's like training all over again at the bedside. No problem. I'll just say, I'll speak from my experience. And that is when you look at certain medical subspecialties, it's rare to have women and in a lot of these subspecialties. And I'll just, again, share my personal experience, and that is cardiology. So, something like only 13% of practicing cardiologists are women. But cardiovascular disease is the #1 killer of women in the United States. There is there's a huge disconnect there. And, you look at other when you look at the data, 50% of people that go into medical school are women, but then as women, we kind of tend to sub-select. You see a lot of women that go into OBGYN, a lot of women that go into pediatrics, but then there's just other places like orthopedic surgery, for example. You can't find, a female physician in that specialty. And so I think one particular challenge is, how do we encourage women, African Americans, Hispanics, these groups that are really missing? I mean, there's a big gap, there's a hole when you look at that and say, what are we doing from the very beginning when these folks get into medical school, when they are training, when they're at the bedside, to encourage them to go into these specialties? And I think that, we have to make sure that that we are providing the role models for these physicians to be, or these APPs to be, and show them that that is kind of compatible with all the things that that they may want in their life outside of their career, and show them how fruitful and just how fulfilling it can be. But that is one particular thing that I really see, is that we have really got to focus on, kind of, again, just backing up when we talk about medical education, is finding, making sure that that we've got all the right people in the right places.
Dr. Walker, your thoughts about some unique challenges?
I'm actually gonna fall back on a clinical issue as well. Dr. Sharma brought up the fact that, we do have a lot of women that go into the OBGYN specialty. I'm one, so I can certainly agree with that. And yet, within the United States, the morbidity and mortality of women in terms of pregnancy, it's appalling. And so we have numbers here that are worse than some third world countries. And so the juxtaposition of that is really bothersome. And at the end of the day, there's been research done about, well, what is the underlying issue? And like many things, it really goes down to systemic racism and the stress that puts on a certain subset of women. So overall, we have an issue with maternal morbidity and maternal mortality, but within the minority populations, it's even worse, and so that, I think, is a unique clinical example of something that we are really struggling to bring to the forefront, and because it's an uncomfortable conversation, it's uncomfortable to think about, and yet at the end of the day, the leading thing that we've come up with is the stressors from functioning in a society that has a lot of systemic racism that ultimately lead to both physical and emotional or psychological impacts that lead to poor outcomes for certain women. And in 2021, the fact that that's still happening is just, it's ridiculous. So I think that's one thing that's unique. That's a very clinical thing. In terms of an administrative or a business example of that, I think it's what we're currently, we've had this whole panel discussion, and we've done a lot of talking today, and we are physically doing some good things at our organization. So I'm certainly not downplaying that, but it is a long road, and so just getting people involved, getting people to understand that this has to be a priority is a unique challenge. It's a lot easier when you have something that is I don't know, not touchy-feely. I don't know if that's the right word. I'm searching for a phrase, but everyone wants to, in business, it's all about the bottom line, so you have to make a case for why this, why focusing on diversity and inclusion, it is additive to the bottom line. And I know that Joanne can probably speak about this a whole lot better than I can, but making that business case, I guess, is what I'm trying to say. for why this is so important is a challenge, because it takes a lot of effort and money and skills and FTEs, that you don't automatically see. Ooh, we're making money off of this, so it's an indirect benefit that we get. But at the end of the day, it's huge in terms of what Joanne was saying about what she was saying earlier about how the diverse teams perform better. And so at the end of the day, you're getting the benefit from it, but it's not easy to see on your spreadsheet.
Mm-hmm. And I think both of these doctors have been very astute in their comments. All I will do is say, I think the unique challenge that I see, they've summed it up great, is courage. Courage to take what Dr. Walker said and do something about it. Courage to note that the morbidity in African-American women with babies is real. Courage to do something. Courage to look at the fact that we have 13% of women who are cardiologists. If you look at the ethnic minority women who are cardiologists, even smaller. To do something about it, to start having discussions with people when they're in middle school and high school, as they're making their career choices, but also courage for each and every one of us to be willing to be uncomfortable and to change. Because growth comes when we move out of our comfort zone to say, I want to be intentional in looking at hiring. I want to be intentional in looking at medicine. And that requires action. Again, diversity is a fact, but inclusion is an act. We have to do something to include people, to be inclusive. We cannot sit where we are and look out the window. It requires something. And a lot of us, that book, Who Moved My Cheese? We don't want anybody to touch that cheese because it is well with me. I want it to be just the way it is. But as we look at what's happening in our community, in our country, in this world, if our organizations are going to be relevant, if they're going to be sustainable, then we're going to have to make change because the world is changing. And I think one of the challenges is people having the courage to say, I don't want to be archaic. So what can I do to improve, to move the needle forward? I wake up every day with impact on my mind, with I'm uncomfortable each and every day. I walk in the room, I enter the Zoom sometimes, and I'm uncomfortable because people are like, here she comes, we're good. It is not good. And if it is good, can we make it great?
Absolutely. So continue to encourage folks to send questions. I am appreciating seeing these come through. So some additional questions that we have. A challenge for the LGBTQ community is the ability to receive medical treatment without being shamed or looked down upon in rural communities. Some providers voice concern with the trans community because they disagree with the change of how someone identifies versus the birth sex. Has anyone done anything to address issues in suburban or rural areas which tend to have beliefs that can lead to LGBTQ patients not going to their providers to get to obtain treatment?
Well, one of the things we're doing is a start. It's not necessarily for rural, but it's just across the board with looking at working on our functionality when people come into our facilities, our clinics, and our hospitals, to have particular things, how to talk to people concerning their sex, their gender, and their name, to call someone what they want to be called. Someone could be transgender, and we can see that they are now female and they want to be called Barbara. We should not be calling them Bobby, and that takes expertise, particularly for people who they have their own unconscious bias. So the training is one thing that we're doing, but we're continuing to have focus groups and discussions on how we can get more embedded in this, because we're seeing it a lot. The last thing we want is for people to not want to come into our healthcare facilities to get the care they need because they fear they'll be shamed or not treated the way they should be treated.
And I'll give a plug here to my alma mater, Mercer University School of Medicine. For those of you that aren't familiar with Mercer, the mission of Mercer is to train physicians to work in rural and or underserved areas of the state. And Mercer only accepts students into their medical school that are Georgia residents. And so because of that unique mission, they have some curricula that are geared towards making sure that their students, when they do finish, their residency or a fellowship or what have you, and they come back to practice in these rural communities, they have received some training that will help them navigate and care for patients that are LGBTQ or, have otherwise not mainstream care needs. And when I was Dean of Diversity, Equity, Inclusion, I made sure that I was an advocate for curricular changes that would support the education of students, of our students, in light of that. And I'm not in that role anymore, but I am confident that those efforts have continued.
The one thing that I would say that we really haven't talked about so far, but something that always kind of looms in the back of my mind when we think about, equity of care, and that is access to health insurance. When Dr. Walker was talking about, high rates of postpartum, maternal morbidity and mortality. We know that Medicaid provides a lot of care for these pregnant patients, but then, what is it, Dr. Walker, like 2 months after these women have their baby, Medicaid goes away. And that's when a lot of them have, in particular in my world, their cardiovascular complications. And I see the same thing with the LGBT communities, but there's really a problem with access to health insurance. And I think once we figure as we all know, this is something we've talked about at a national level for a long time, but I think this is, again, what I personally consider, again, when I see taking care of my patients, this is something that's foundational. When we talk about equity of care, access to care, we're talking about health insurance, and we've got to figure out a way for our patients to get this so that they can get in the door. It's really not sustainable any other way that I can see with the current system that we have.
The next question, I think, is an excellent one, and the next two questions are somewhat related. Are there any suggestions from the panelists for receiving training or providing training to healthcare executives to have the courageous conversations around diversity, equity, inclusion, and health disparities? It seems scary to have these discussions without having a plan on for how to facilitate the conversations to move us forward.
Well, I can say from Piedmont Healthcare, when I was interviewing for the position, the CEO, Kevin Brown, he said, we really need unconscious bias training. We need to know what our biases are and how to address them. And so again, we are working on a complete curriculum within COVID and vaccine. Some of our efforts were sort of put on hold, if you will, and we are trying to move that forward. But I think even with not having formalized training, I do believe that, first of all, there has to be an acknowledgement that the things are not equal, that there are opportunities for improvement. To me, it starts right there, even to the second question, how do you, even in a private practice where you don't have the whole corporate support, how do you look at what it takes to move the needle in your leadership table? The first thing you do is you look around and you acknowledge that there is an area of opportunity, that everybody looks the same. That's the first thing. And then this may seem so simplistic, but I really believe it, and I speak it and I preach it. We have to ask people what they want to do. You see, we like to assume. I want to assume that because I'm a nurse, I just always want to be a nurse, want to be a CNO. Maybe I want to go back to school and be a doctor. But we have to ask everyone what it is that they desire. What is success to them? Not just the people that look like us, went to school with us, the people that we have a drink with, we know, but all of our team members. That right there to me is foundational, because I cannot tell you how many people have left Piedmont. There may still be people, they'll say, no one has ever asked me what I want to do. And I want to see myself moving up here If I don't see myself being what I want to be here, then I'm just going to go somewhere else. And I say this often. I said, do we want our best and our brightest to leave us because they can't see? When you mentioned, Dr. Walker, that you have your first African-American CEO, a part of me was happy and a part of me was sad, because in 2021, the fact that we're just getting a first in some of this, I'm like, why? But I'm also the same person that says, why do we celebrate Black History Month when Black history is being made every day? Women's history is being made every day, Hispanic history, because somehow we have to stop and do that, because if not, someone will not acknowledge it. So to the people on this call, my question is, when will I stop that and start acknowledging that everyone has a place and being really impactful with that? That's where it starts. I mean, I don't need anyone in the federal government, in the state government, the city government to start telling me how to do the right thing. We were born knowing how to do that. We just have to do it and do it now.
Thank you, Joanne. Any other suggestions in terms of training? Because I know for my organization, we looked internally and then turned around and said, we need help because we're not sure we know what we're doing and how to do it properly, and spent a lot of time researching and identifying external agencies to provide us a framework to build our diversity, equity, diversity, inclusion, and belonging program for within Sound Physicians. So Dr. Walker, Dr. Sharma, anything else that you would want to add?
I mean, I do know that we have resources. We have a whole toolkit actually that came from the enterprise level that has some information on how to have those courageous conversations. The good thing is now with the internet, that there are a lot of free resources out there. It's just a matter of going out to look to see, what you think you could most benefit from. But I also want to encourage people and to just reiterate what Joanne said. It's not necessarily about the training. It's about being willing to be vulnerable and to sit down with a colleague and just say, hey, let's have a conversation. There's not enough training in the world that's going to make that's probably going to make that a less comfortable, a less awkward start. And yet, once you get going, I think you will realize it's not hard. You don't need a notebook to do it. You just need to be able to be vulnerable. And while that may not be comfortable, the more that you do it, the more comfortable you'll get, and you'll realize that this is just a part of what I need to do in my personal growth, in my professional growth, is to just begin to reach out and have those conversations.
Mm-hmm. All right. This is a related question, but I think focused at a different scale. Many private practices without health system level resources acknowledge that they do not have a leadership representative of their diverse staff and patient communities. Assuming they already have a supportive culture of inclusion, how do they get started in an authentic way? I think that's the summation of the question is with people with fewer resources, and maybe this gets back to what you were suggesting, Dr. Walker, but anything specific we would otherwise provide to answer this question?
Well, I question, the person saying, well, they don't have leadership representative of their diverse staff, but they have a supportive culture of inclusion. Questioning that a little bit, but like Joanne, I'm going to be on my best behavior.
No, I want you to be yourself. Courage, come on. Because I'm thinking the same thing, side eye.
So you may not have as supportive of a culture as you think that you do, mm-hmm. if that's where you struggle. And I would say to again go to your staff and say, yes. We've recognized that in our leadership we don't have we're not diverse. What do you suggest? Your staff may be a part of a network that you are unaware of. They may be a part of a professional network at their level that they have contacts that could introduce you to a more diverse, leader in whatever capacity you're looking for. So I would start with that, and also, really be honest with how inclusive, your current, system is. Everybody's got to start somewhere. So don't get me wrong. I'm not, I don't want to end on a negative note, but again, we've got to really be honest with ourselves and say, is there a reason why we don't have leadership? Are we as inclusive as we think we are? Are we scaring people away? Are we being inviting so that we attract what we want?
You summed it up. Courage, communication. You got to have courage. You have to ask people. Like you said, the staff knows. They can tell you. But you have to be willing to put yourself out there, to be uncomfortable, to ask those questions so that you can fix whatever it is that could be broken. They'll tell you. They're talking about it anyway.
All right, we have made it through the questions that are in the queue. We have a few more minutes before I would want to shift to our panelists and have them thinking about their closing comments. But I want to give our participants a little additional time to enter these. So please enter them into the chat under everyone, or if you don't want to enter it to everyone, you can send them either to Ricardo or myself, preferably me, directly in the chat. And I apologize. I am very comfortable with uncomfortable silence to allow people plenty of time. I never warn people in advance of that, only the ones that work with me on a consistent basis. But without seeing any specific questions coming up, I will ask our panelists to just give some their final thoughts with respect to the topic, and it's really your choice. And so first I'd ask Dr. Sharma, if you could please share your final thoughts before heading back to see your patients.
Yeah, sure. Well, I have enjoyed our lively discussion for sure. Best lunch I've had in a long time. I would just say a couple of things. I would just go back and say where we started, which was talking about the COVID vaccine. I think it is just so important for our individual patients, for our state, for our nation, to make sure that we get as many folks vaccinated as possible. And this idea of going back to meet patients and people in our communities where they are and answer their specific questions and try and get out the truth, as Joanne was saying, I think is really important. And I guess the last thing that I'll say is, as we've been talking about having these courageous conversations, I'll just reiterate, I was so flippin' nervous the first time, I was going to sit down with all my partners and say, how are we going to use this type of information to amend our hiring practices and the ways that we're going to start treating our patients? And I had that conversation with one of my partners who I really trust off to the side before I went into the big meeting and said, hey, look, this is what I'm going to say. What do you think about it? And anything I should do, up, down, left, right, help me, give me some feedback on it. And then it felt so wonderful to me to have kind of my partner going into this conversation. And as soon as I said, what I said, my partner was right there with me. Yep, absolutely. I agree with what Jyoti's saying. This is important. Don't you guys think? And to me, that was so, again, it just felt so nice because it is difficult. Joanne has a visitor. But it was really wonderful to have truly I felt like in the truest sense of the word, a partner to go into this conversation. So that was the last thing I'll say. Good to go into those type of conversations with that kind of person.
Oh, thank you for that. Joanne, I know that you enjoyed your having that young man behind you, but I'll go ahead and let you get your summary comments before turning over to Dr. Walker.
Yes. Well, and my summary is, when I joined Piedmont Healthcare, I was attracted to the promise to make a positive difference in every life you touch was so much aligned with my own personal goals. I had retired, was really going to work in my own nonprofit I had just started, which is all about helping people, particularly women, and in comes Piedmont. But that 14-year-old who walked behind the camera, because I am working from home today, is part of my legacy. I believe I have a responsibility for him and for my 27-year-old son, Morehouse grad, to to leave this world in a better place than that which I found it, so that they won't be sitting on a panel talking about systemic racism and all the inequities and celebrating that we have a woman or a brown person or LGBTQ person who's in a position of leadership, because it should have already happened. And so I will just leave all of you with this, to say that every single person that is on this webinar and the people that you know, you're all important. You're all valuable. We all have a place at the table. But I just encourage us not only to take the seat for ourselves, but take the seat and make sure we bring someone else along, maybe someone who doesn't look like us, who didn't go to school where we went, so that we can continue this world. It's okay to be uncomfortable, because that is where we will find growth. Thank you.
Thank you, Joanne. And finally, Dr. Walker.
Well, how can I go after Joanne? No,
bring it home. Bring it home. You inspire me.
It has been such a pleasure to spend this time in the middle of the day to have this conversation. And honestly, you know, even though us 3 or 4 people have been the one talking, those of you that have been listening and typing in your questions, guess what? You've been a part of a courageous conversation. You're doing it right now. You know, sometimes we overthink it and we think that we've got to have a big meeting and we've got to bring a lot of people together. And that's one way to do it, but it's also happening. It can happen in private, one-on-one conversations, and while we're getting ourselves a cup of coffee and we see somebody in the break room or what have you, you know. And so I just think that I want to encourage everyone to know that you can do it, that each one of us in our organizations, in our home department and unit, and in our social interactions with people not at work too. I mean, there's nothing special about the fact that we're here and this is a, you know, a GAHE event, that whether we are at work or in our social lives, we need to continue to have this mindset all the time. And so the things that we've talked about today, hopefully people have heard something that moved them, that you've learned something that you feel like you can take away from it. And if that happened, then I think, you know, we accomplished something. And I'm just proud to have been a part of this panel. And I thank everyone for their time and attention. And just, wow, it's been great.
Well, thank you, Dr. Walker. And before I turn it back over to Trent, I want to thank all of our panelists for doing such a magnificent job and being so passionate, informative, and insightful. I know I learned something from the 3 of you, and it was a pleasure to participate in this panel with you. And turn it back over to Trent in terms of thanking GAHE for hosting this. And Trent, it's over to you.
All right. Thank you, Dr. Johnson. Really appreciate you moderating a great session. I already see a lot of the comments coming online of just how well received the discussion was. And I think, again, just some really good takeaways. Our panelists, just an amazing group of individuals who are all just really leading the charge and helping us to get comfortable having the discussion, because I think that's the first step, no doubt. I loved, and Joanne, you were on your best behavior. Thank you. I love, and I'll make sure I'll pass that along. But love the fact that you shared a quote, and I hadn't heard this yet. Maybe I'd missed it. But diversity is a fact, inclusion is an act. Love how that's phrased. Again, I think without action, we don't take steps forward. And I think all of us in our individual organizations need to be really mindful of what actions we are taking to help move the agenda in the right way, so that we can all be at the table and be making the decisions at the end of the day for our patients, because that's where it's at, and that's what we're here for. Again, just thank you to our programs committee for putting an amazing session on. You know, both Amanda Mewborn, Angela Henry, and the entire committee. Thank you. Again, it's been really on point this year, and just so proud this year and last year, and then so proud of the work. Thank you, ACHE. GAHE can't do this without you. So Ricardo and team, really appreciate all that you're doing to help us put these face-to-face educational sessions on. Please continue to stay connected to GAHE via our website, via all of our social media outlets, and then also make sure that you go out and assure that you fill out the evaluation form. We get great feedback from you, all of our membership after these events, and helps to make us better when we get good critical feedback. But really appreciate that. So with that said, again, thank you, panelists. Thank you, Dr. Johnson. Appreciate, again, a great session and really thought-provoking discussion. And on to Ricardo to kind of wrap us up here. Thank you.
Thank you, Trent. Thank you to our moderator, Gregory, and everyone, panelists, thank you for your participation today. This concludes our session. Again, today's session is worth 1.5 hours of face-to-face education credit and will be applied to your AACHE account in approximately 2 weeks from today's session. Please be sure to complete the evaluation by visiting your My AACHE page and selecting My Online Learning from the helpful link section. From there, click on the Access My Courses link and you'll be directed to the LMS where you can complete the evaluation. The recording for this session will be posted in the LMS within 48 hours of today and will be available to download. Today's program is copyrighted in 2021 by the American College of Healthcare Executives, all rights reserved. Thank you for attending and continue to stay safe, stay safe, everyone.
Take care.
Thank you, you too.
Bye.
Bye-bye.
Bye-bye. Thank you.
Bye-bye.
Bye-bye.